Next, we have Dr. Lathika VK. She is presenting on submacular detachment as a biomarker of therapeutic outcomes in BRBO, a prospective cohort study.
Good morning. My paper is on submacular detachment as a biomarker for therapeutic outcomes in BRVO. Macular edema is the leading cause of impaired vision in BRVO, and submacular detachment contributes a significant proportion of macular edema cases. So it is very relevant for clinicians to know whether SMD impacts the therapeutic outcomes or prognosis. So we have conflicting evidence on this, and that is why the study was designed to assess and compare the therapeutic outcomes following intravitreal ranibizumab in BRVO patient cohorts with CMD and those without CMD. It was a prospective cohort study done in a tertiary care teaching hospital over 18 months on 60 patients who were recruited by consecutive sampling. All patients with BRVO and macular edema who were treatment naive and had a defective vision of less than 2 weeks were included. Patients with coexisting retinal disease and not consenting to participate were excluded. The study population was grouped into cohorts of 30 each with and without SMD, and both underwent intravitreal ranibizumab injections 0.5 milligram, and they were assessed at 2 weeks and 4 weeks following the intervention by the same examiner, and all of them underwent complete ophthalmic evaluation and SDOCT examination. The primary measure of the treatment therapeutic outcomes that we looked at were the BCVA and the CMT reduction, and the secondary measure was the decrease in SMD per se. We also looked at the pattern of therapeutic response, as in which group exhibited a faster response and a more sustainable response. Therapeutic outcomes in each group over time were measured using the pair t-test and the Wilcoxon sign rank test, and the difference between the groups by the independent t-test and the Mann-Whitney U-test, and p less than 0.05 was considered statistically significant. The mean age of our population was around 63 years, and males outnumbered females. All of our patients had hypertension. So coming to the crux of the problem, we found that at the baseline, BCVA was marginally higher in the non-SMD group. Both groups had a statistically significant increase in vision at 1 month and also at 2 weeks. You can see the number of Snellen letter improvements. It was 8 letters in 2 weeks versus 10 letter, 13 letter versus 11 letter. So the highlight is that though both groups improved, there was no statistically significant differences in the BCVA improvement. That means both SMD did not matter actually regarding the final BCVA attained. So but the trend of BCVA improvement over time was different. In the non-SMD group, you can see that in 2 weeks itself, 10 letters improved. Then it sort of plateaued off. That means there was a rapid response and better vision at 2 weeks and almost plateauing thereafter. Whereas in the SMD group, the visual improvement was rather uniformly distributed over 4 weeks. Going on to the CMT changes, the baseline CMT was higher in the SMD group by around 200 microns, and both groups exhibited significant reduction at 2 weeks and 1 month post-injection. However, if you look at the rebound, both had rebound edema after 2 weeks. If you look at the rebound, you can see that it was more and more statistically significant in the SMD group. So what does it say? It says that there is a more rapid, stronger and sustainable anatomical response in the SMD group with less of a rebound happening. We also looked at SMD reduction per se. So the baseline SMD height was 220 microns. It decreased by 51% at 2 weeks and by 63.5% at 1 month. And most of this resolution occurred in the first 2 weeks, probably reflecting in the CMT decrease also. So these are the images showing this therapeutic response, and many studies concur with our studies in that the eyes with SMD has a better anatomical response and comparable visual outcomes, but there are studies in discordance saying that final BCVA was better in patients without SMD at baseline. Actually, the strength and limitation of the study happens to be the same, that is the short follow-up time. Because of the short follow-up, there was nil attrition of the sample, but naturally we could not follow up all SMDs to their complete resolution. So in conclusion, SMD in BRVO responds well to ranibizumab with peak reduction happening at 2 weeks. SMD is a biomarker for significantly faster, stronger and more sustainable anatomical outcome as measured by CMT reduction, but it is not a biomarker for significantly better visual outcome. Visual outcome was actually slightly better in the SMD group, but it was not statistically significant. The BCVA improvement was more rapid in non-SMD group, while SMD took a little bit more time to reach the same visual outcome. So what is new about this study? This study offers new insights into the influence of SMD on the trend and the response curve, therapeutic response curve of the groups in terms of BCVA and CMT. We have studies focusing on the quantum of improvement, but not how it is improving over time. And the specific effect of IVR on SMD resolution per se, independent of CMT, was also studied in this group. And this, of course, is real life data from our part of the world. So what happens next? Why is the relevance of this study? It's because the presence of SMD need not threaten retinal specialists and clinicians. It does not mean a worse visual outcome, though patients may need to be counseled for a more gradual visual recovery. So this study, if translated to evidence-based medicine, can definitely help clinicians set realistic expectations regarding therapeutic outcomes post-intravitreal ranibizumab in BRVO patients with SMD. These are my references, and thank you all for your kind attention.
Is there anything new for which you decided to do this study, which was not there in literature?
Yes, because the role of SMD was more clear in diabetic patients. In BRVO patients, there were studies saying that patients with SMD had significantly reduced vision compared to those without SMD. There are some reports saying that they have a comparatively good vision in the, so there were conflicts between the reports. So when we see a patient with and without SMD, the clinician is rather confused on actually what to expect regarding a therapeutic response. Is there a difference? That is one thing. And we also did not know how fast the differences in the sustainability and the rapidity of the response was not there in the studies. So I think that adds value.
You said none of them have ocular issues apart from BRVO, isn't it?
Yes.
Yeah, but 100% of them have hypertension.
Yes.
So wouldn't hypertensive retinopathy be a confounding factor?
We excluded those with any other sort of retinopathies.
Okay. And
all other retinopathies.
How much of this would you attribute to, for example, BRVO is a very significant event in the patient's life.
Yes.
So the moment you diagnose that and you say hypertension, how much of the recovery from intravitreal could be attributed to the control of hypertension after the procedure?
Actually, all these patients, we take a fitness before IVR injection also. So they were all undergoing concurrent systemic hypertension control as a part of treatment itself. So I think that's equally important. Yes.
Next presenter is Dr. Jyoti Krishnan. Her paper is on to compare the utilization rate of hospital and voluntary retrieved cornea in an eye bank in Kerala.
Very good morning to everyone. And my study is to compare the utilization rate of hospital and voluntary retrieved cornea in an eye bank in Kerala. So hospital cornea retrieval program, HCRP focus on hospital-based death, encourages eye donation using a combined method of motivation and grief counseling. And what are the advantages? There's readily available medical history, availability of younger tissue, lesser time spent in cornea retrieval, and cost effectiveness. And voluntary eye donation. Voluntary eye donation is the act of pledging to donate one's eyes after death. So the Eye Bank Association of Kerala established in Nittival Hospital, Angamali in the year 1970. Even though we started HCRP, voluntary is the whole strength of our eye bank. So from literature, we found that the better quality tissues are from the HCRP, and most of the studies of 1 year duration. So we analyzed our data of 4 year and 3 months data to assess our utilization and what are the post-COVID trend in eye donation in Kerala. We have 8 collection centers and around 300 registered volunteers. This is a retrospective record-based study, and duration is from the 2020 January to 2024 March. All the records of the cornea retrieved during the study period were analyzed. We stratified the corneas into HCRP and voluntary, and the following variables are studied like demography, suitability of the tissue, type of surgery and utilization, and causes for rejection. The data analyzed with the SPSS software and a chi-square test was used to analyze the all categorical variables and all categorical variables expressed as percentages. Results: total 5081 corneas were assessed. In this, 3021, 59.4% in voluntary, and 1880, 37% in HCRP group. The age distribution of donors shows that most of the donors belongs to the age group of 60 to 80. When we compare HCRP and voluntary group, we can see that the most of the younger tissues are from the HCRP group, and we can see that in 41 to 50 years of age, almost double the amount of corneas are collected in HCRP. And a main predominant pattern is seen in HCRP and voluntary group. The table shows total year-wise utilization of the cornea, and we can see that in 2020 and 2021 there is a fall in collection. Even though there is a fall in collection, there is better utilization of the available tissue can be seen, almost 76% and 82.1% of tissue. And these are the comparison of utilization between HCRP and voluntary group, and we can see that there is a more percentage of the tissues are utilized in HCRP group. So after retrieval, we assess the tissue for its suitability for further surgical procedures. In HCRP group, 1576, almost 80% of the corneas are suitable for further transplantation. But meanwhile, the only 60% is not suitable in HCRP group. In voluntary group, almost 42.6%, 1360 corneas are suitable, but 1838, 57.4% tissues are not suitable for surgical transplantation. These are the surgical utilization in HCRP in voluntary. In HCRP, almost 60% of the tissues are utilized for optical transplantation, and that 44% is for penetrating keratoplasty, 17.1 for DSEC, and 7.9 for anterior lamellar keratoplasty, and 30.8% tissues are utilized for therapeutic keratoplasty. While in voluntary group, 28% is utilized for the optical purposes. In this, 24.6% for penetrating keratoplasty, 3.3% for DSEC, and 0.3% for anterior lamellar keratoplasty, and 14.15% is used for therapeutic keratoplasty. So we assess the corneas tissues as wall globe and corneal button, and from the graph we can see that 95.7% of the corneas retrieved in HCRP group as corneal button. Only small percentage is retrieved as wall globe. But in meanwhile in voluntary group, almost 50% of tissues are retrieved as wall globe and corneal button. And most of the wall globe in the voluntary group are used for surgical purposes, so research purposes. And what are the reasons for not using a tissue for surgical purposes? We found that there is very old age, foreign body, infiltrate, cancer metastasis, medium color change, and scar suggestive HSV keratitis and serology. And most of the discarded tissues belongs to the voluntary group. And we also assessed the expired tissue. And in 2839 suitable tissue, only 12 tissues are expired, and that is 11 from the HCRP group and 1 from the voluntary group. So my conclusion is, our study is the first ever iBank study from Kerala with a big data analysis and a duration of 4 years and 3 months. And we found that the younger tissues and suitable tissues and transplantation is more in HCRP. So from the slide, we can see that during 2020-2021, when the India and the world were suffered from the COVID pandemic, even though the retrieval rate was so low, the available tissues are better utilized, 76% and 82.1%. And that data is compared with the data from the one other state in India, even with the international data. And after COVID, we can see that there is a rising pattern with better utilization and retrieval. So it shows that there is a effective eye banking was done during COVID and are still continuing. And when we compare with the studies from the other state eye banking study, we can know that Kerala is a small geographical part of India with a small population. Even though our population is so small, the results are comparable. So one study done by Dr. Narmada Sharma in 2018 in National Eye Bank of India with 40 months of duration, the results are so comparable. So our eye banking rate is, our eye banking system is so effective. So interpretations, we have to we have to reach out to all multi-specialty hospitals and ask them to link with our iBank and FT communication with the corneal surgeons, and various public awareness program and voluntary appreciation program have to be done. So let your eyes live on. Don't destroy it. Donate it. Thank you.
Your utilization, the lack of utilization you showed, no, the slide is, there's a different scale for VFS and also HCRP.
Yes, sir.
The scale is, one scale is, so if you look at the graph, it looks similar, but actually it should not be. The scale
Sir,
you have put
the
is,
total number is different, sir.
yeah, so
sir,
you should not represent it like that, because if anybody looks at it,
it's
it
almost
looks like
same. Okay, sir.
so that's a lot of discrepancy. I mean, there's a difference, gross difference, the scale.
Yeah, sir, but the numbers are different. So from the number, it's
Not this, the non-utilization. Yeah,
this one. This one.
no, no,
The
another one.
that issue they used for surgical, research purposes.
So because there's a lot of resources are being, wasted in retrieving those eyes and then not utilizing it.
No, sir, we have to create a public awareness. So even one person is voluntarily they are willing to donate their eyes, we have to promote.
No, that is true, but that is what is happening. But still, you're not able to utilize it.
Yeah, we can use it for research purposes, sir, like various wet labs, like PG training, and even for research purposes, we can utilize that. It's not wastage.
Oh.
Thank you, sir.
Next, we have Dr. Ranjini H. Her topic is on burden of ocular abnormalities among children with disabilities in special schools of South India.
Good morning. My paper is on burden of ocular abnormalities among children with various disabilities in special schools of South India. I have no financial interest in the study. So children with disabilities, they constitute a very critical part of our population, and their assessment of vision is often overlooked because the main focus of the parents is on the primary disability. So there is a need for a very timely and comprehensive eye evaluation for this vulnerable group. So aim of our study was to assess the visual function of children with neurodevelopmental disability and to identify preventable and treatable ocular abnormalities. Ours was a descriptive, cross-sectional and interventional study conducted over a duration of 1.5 years from August 2022 to January 2024. Total 216 children from 6 special schools with various neurodevelopmental disability were examined. It is very challenging for the parents to bring these children to an hospital for an eye checkup. So we approached these children through our mobile eye clinic. Our team consisted of an ophthalmologist, optometrist, optometry interns, and caregivers. We took detailed history from the parents or teachers. We took their consent for examining these children. Visual acuity was assessed with the help of Snellen visual acuity chart, tumbling E or LIA symbols for children who were cooperative and able to respond. And in children who were uncooperative, we assessed their fixation and following behavior by CSM method. All children underwent a detailed anterior and posterior segment examination. Cycloplegic retinoscopy was done in all children. So here is a short clip of our mobile eye clinic. It's a fully equipped bus consisting of all the relative facilities and instruments required for a detailed eye checkup. Coming to the results, The males outnumbered the females in our study. The mean age group of presentation was 17.15 years, means the maximum age of presentation was in the age group of 10 to 20 years. Coming to the distribution of disabilities, the disability with maximum presentation was autism and intellectual disability, followed by speech delay and Down syndrome. The other disabilities which we noted in our study was hearing impairment, cerebral palsy, attention deficit hyperactivity disorder, seizure disorder, and global developmental delay. There was a history of preterm birth in 21.3% of children, and there was statistically significant association between preterm birth and cerebral palsy. Coming to the distribution of ocular disorders, refractive error was the most common presentation, followed by strabismus, optic dyspallor, and cataract. In the strabismus group, exotropia was the most common presentation. We noted hypermetropia to be the most common refractive error in our study. Coming to the distribution across the disabilities, we found that children with Down syndrome has maximum presentation, followed by cerebral palsy. There was a significant statistical association between Down syndrome and hypermetropia. Similarly, myopia was most commonly present in children with autism, followed by speech delay. When we saw the presentation of strabismus, dyspallor, and cataract across the disabilities, we found that the children with cerebral palsy and Down syndrome has more presentation. Also, dyspallor was commonly presented in children with cerebral palsy. Cataracts was seen mostly in children with Down syndrome. When we looked at the association, we found that there was significant association of strabismus in children with autism, hearing impairment, and cerebral palsy. Also, there was significant association of dyspallor in children with cerebral palsy. So we rehabilitated these children with glasses. We advised occlusion for children with embryogenic risk factors, orthoptic exercises for children with convergence weakness, low vision aids was advised, and we referred children to the base hospital requiring surgery. So it has been already documented that children with disabilities are at greater risk for oculovisual disorders as compared to the age-matched control. So there is a need for an efficient ophthalmic screening and evaluation for these children. And why it is important? Because these children are dependent on vision for their personal and educational needs, and especially these children cannot come to the eye hospital for a detailed evaluation. There are various studies done in the past studying these children, but what makes our study unique is our mobile eye clinic and accessibility and affordability of eye care for these children. So if these children can't come to us for a checkup, we went to them and approached them for a detailed eye evaluation. So I would like to conclude by saying that there is a need for a community-based screening, and especially teachers who can be trained for a preliminary eye examination like assessment of visual acuity, so that the risk factors can be screened and there can be a timely rehabilitation for these children. These are my references. Thank you. Ma'am, all the children were having some neurodevelopmental disability, ma'am.
Because it's a known association.
Yes.
I mean, nothing what you have presented is surprising. You just put it. Because all these associations are known associations for many years. If you go to a special school, any part of world, you are going to find something similar. So, what is your take on it, except having a mobile van to see that?
What we noticed, ma'am, that these children were not undergoing a eye evaluation. So that was
Were wearing glasses?
most of them. We had 43% of the population who had refractive errors.
No, but how many already had prescriptions?
Yeah, so there was a combination of them, ma'am. Children were there with glasses, but then many of them were not very compliant with the glasses, or they were not aware of the importance of spectacles.
And demographically, were they different? Were the children from all over South India, or how was it? Like, were they-
Mainly children from Ernakulam, sir.
Usually these centers, they don't have access to eye care, so somebody has to go and visit them. That initiative has to be taken.
What a
Especially children with cerebral palsy who are not ambulatory. Yes. Okay, thank you.
Next presenter is Dr. Anna Kurian. Her topic is the rise of orbital dyrofilariasis, insights into its epidemiology, diagnosis, and management.
Good afternoon. My paper is on the rise of orbital dyrofilariasis, insights into epidemiology, diagnosis, and management. It is an emerging zoonosis transmitted through the bite of mosquitoes. The most common affected ocular site is subconjunctival space, followed by eyelids and orbit. The major species of medical concern are Dirophilia repens and immitis. The prevalence of repens is found to be 7 to 24% in stray dogs in Kerala in studies conducted by veterinary doctors. This is important because it is the most favorable definitive host. When the worm cannot be isolated from the subcutaneous excised mass, species-specific polymerase chain reaction helps. My primary aim was to study the clinical pathological characteristics of patients with a confirmed diagnosis of orbital dyrofilariasis, and secondary aim was to highlight the importance of PCR in confirming the diagnosis. This was a retrospective study done on 39 patients with confirmed case for a study period of 2 years. Patient demographics, treatment approaches, and postoperative outcomes, blood parameters, mainly absolute eosinophil count, were included. All patients underwent orbitotomy and histopathological examination. PCR was done on only 31 specimens, 8 opted out due to financial constraint. Follow-up was done at 2 weeks, 1 month, and 3 months. All patients whose biopsy and or PCR confirmed the diagnosis were included. Patients who did not undergo surgical excision were excluded. Out of the 39 patients, 17 were in the age group of 41 to 60 years with a slight male predominance. In 2022 to April 2023, we saw 36% of our patients. It almost doubled in the second year, 2023 to 2024. The highest incidence of cases were noticed during June to August, the monsoon season. The most common duration of presentation was 3 to 8 weeks, seen in 51%. Only one patient had a disease duration of more than 15 weeks. Only 3 of our patients kept canine and 2 had feline pets. However, most of the patients lived in the vicinity of stray dogs. This is the geographical distribution of our cases. We had most of the patients coming from Thrissur, and maybe whether it has a bigger epidemiological influence, it needs to be studied on a bigger scale. The most common symptom was swelling with pruritus, seen in 16 patients. All of the lesions were in the anterior orbital space, with 13 being in the supraorbital region and 10 being the infraorbital. Coming to the signs, 23 of our patients presented with the presence of a mass alone. 16 patients had minimal inflammation, mainly edema, 5 of which showed skin fixity. The absolute eosinophil count was elevated only in 8 patients. None of our patients were immunosuppressed. All 39 patients underwent orbitotomy, out of which only 16 biopsy specimens showed the presence of a dead or degenerated worm. The presence of the multiple lumina within the mass is also an indicator of Dirophilaria infection. This is the cross-section of a nematode with thick cuticle, evenly spaced longitudinal ridges, and a prominent muscle layer. The remaining 23 biopsy specimens showed only fibrocollagenous tissue. Their diagnosis had to be confirmed using PCR, which tested positive for Dirophilaria repens. Out of the 16 specimens which had the worm, 2 gave a negative result for both D. repens and immitis. During the first follow-up, 37 patients showed significant improvement with no palpable mass. 2 patients had persistent inflammation, for which 1 patient needed oral steroids. The second patient required intralesional Kenacort injection. Coming to the discussion, the incidence was found to be higher in individuals aged 41 to 60 and during the monsoon season, implicating an influence of vector control. The rising stray dog population in Kerala may be a causative for the increasing risk of Dirophilaria infection, as evidenced by the prevalence of microfilaria in stray dogs in Kerala. All had localized masses confined to the anterior orbital region, so surgical excision was highly effective. All the lesions were non-tender, firm, with minimal signs of inflammation. So this is an important differential diagnosis in acute onset mass. The 2 cases which were not on any preoperative steroids or antibiotics developed postoperative inflammation. So maybe a short course of steroids in the preoperative period may play a role in the limitation of postoperative inflammation. There is an alteration in parasitic structures and decomposition of worms, so this causes an ambiguity in diagnosis. Hence, polymerase chain reaction is important in confirming the diagnosis and also understanding more about the disease. The negative PCR in the two cases with isolated worms could be due to an insufficient sample, PCR inhibition, or an emerging new genotype. As evidenced by the studies conducted by Pradeep et al. And Kumar et al., they have identified Dirophilaria hongogensis, which is almost similar to the repens species in both animals and humans in Kerala. The main limitation was this is limited to a small geographical area in the state of Kerala. Only patients who underwent surgical intervention were included. So the study population does not actually represent the entire census of the disease. To conclude, the possibility of an epidemic is probably because of climate change, vector, and host mobility. It is important to spread awareness regarding vector control and eradication of microfilariae in their natural reservoir. In an endemic region like Kerala, Dirophilaria is an important differential diagnosis of an orbital swelling. Molecular analysis is important to increase our knowledge of parasite biology and reveal new genotypes. This is my acknowledgement. References. Thank you. This was only for just 2 years, ma'am. I think we are planning to do a multi-institutional if possible, because this is just a very small area in Kerala. So, yep, we.
No, the census also you can get. Dilophoresis is
Yes,
not
sir.
a unknown.
Yes, sir.
You can get from the census data. What are the non-surgical
Yes, sir.
you should have that denominator.
But then it won't be confirmed diagnosis. That's the issue. If it's not surgically excised, unless we have done ELISA, or it won't be confirmed.
Next, we have Dr. Chandrakant KS. His paper is on prospective study of 100 eyes with phacolytic glaucoma undergoing phaco with foldable IOL.
Good afternoon, judges and friends. This paper is about prospective study on phacolytic glaucoma, patients undergoing a phaco with foldable IOL. It was a prospective study run on 100 patients who came to a hospital with pain in the eyes and all, and they were found to have glaucoma, phacolytic glaucoma. Aim of the study is to see the visual acuity, post-operative and post-operative complications in 100 eyes with phacolytic glaucoma who underwent phacoemulsification and foldable IOL implantation. The material and methods, you have got the study design, hospital-based prospective study. It was done in a tertiary care eye hospital in South India. 100 eyes with phacolytic glaucoma were studied. This gives a demographic pattern on the patients. Majority of the patients were in the age of 51 to 70 years. Majority of the patients were in the male group. This slide gives the systemic conditions. Hypertension in 68 patients, diabetic in 42 patients, cardiac in 8, neurologic stroke in 4, malignancy 3, bronchial asthma 8 patients, and patients with rheumatoid arthritis 6. This is a checklist of preoperative tests which was done. Vision was tested. Lacrimal duct patency was done. Slit-lamp biomarkers was examined to see whether there was subluxation, such things and all. A scan here again. There was immersion A scan also done in cases. Then you have got keratometry, the B scan to rule out any posterior segment pathology. IOL power calculation was done with the Barrett 2 universal 2 formula. This gives a preoperative vision. Perception of light and projection of rays, right is in 94 eyes. Perception of light and doubtful projection of rays in 4, and perception of light present, but projection was doubtful in case of 2 eyes. Preoperatively, all the patients underwent antibiotic drops instillation in the form of moxifloxacin. Topical lotoprotein was also applied. Because of the high intraocular pressure, dorzolamide, timolol, azithromycin is a tablet, and all were given IV mannitol depending on the intraocular pressure. Briefing about operative procedure. This was a temporal clear corneal section. Anti-chamber wash was given. Capsulotomy with after staining with the methylene blue dye. Then using viscoelastics and incision of 5.5 to 6 millimeter diameter. Hydrodissection was done. This is a procedure is explained in the video here. This is the case, one of the case. Doing a 2.2 to 2.3 millimeter keratomy incision. Then injection of the dye. You can see that the exudates in the antechamber. After that, it's injected. You do a under viscoelastic. You do a capsular access. 5.5 to 6 millimeter is attempted. It should be done very carefully because of the loose nucleus inside. Once this is done, a slow hydrodissection is done. Then using this phacoemulsification probe, the direct phaco chop, stop and chop is also done. You can see how the nucleus is loose there inside the capsular bag. You have to be very careful lest you could damage the zonules, leading like to subluxation. This is cracked now. Then it should be very gently done. The last piece is hence removed. Then loose cortex, if any, is removed with IA probe. Under viscoelastic foldable intraocular lens, single piece inserted into the bag. The haptic is placed within the capsular bag. Viscoelastic is removed, then hydration of the wound. Wound is closed. You can see the centered intraocular lens. These are the results. At the end of 1 month, 42 eyes had best visual corrected acuity of 6/6, 54 had 6/9, 3 had 6/12, and 1 patient had 3/60. At the end of 3 years, 80 eyes had best visual corrected acuity of 6/6, 18 6/9, 1 had 6/24, and 1 had 3/60. This is the same in the form of the graph. After 1 month, as I said, 42 eyes had 6/6, 52 eyes had 6/9. 3 eyes had elevated intraocular pressure treated with timolol and bremonidine, eye drops 2 times a day. 1 eye had best corrected visual acuity of 3/60, had glaucomatous optic atrophy. At the end of 3 months, 1 eye developed a pseudophakic bullous keratopathy, which underwent penetrating keratoplasty at the end of 9 months. 3 eyes developed posterior capsular opacification. All 3 underwent yak capsulotomy, and good vision was regained. 6 eyes developed moderate iritis, which was treated with intense steroids. Intraoperative, 1 eye had only dialysis. Capsular bag, tension bag was inserted, and eye was kept in the bag. This is the complications already described. Discussion: challenge faced by phacoemulsification in phacolytic glaucoma because of the high milky white cortex, highly mobile nucleus, irregular depth of the antechamber, loose capsular bag, and zonular dialysis. In the series of 100 patients, at the end of 1 month, 42 eyes had a best visual correct of 6/6, 54 6/9. Intraoperative complications were at a minimal. 1 eye had pseudophakic bullous keratopathy, 3 had posterior capsular opacification at the end of the 2 years. Conclusion: phacoemulsification phacolytic glaucoma eyes can be surgically managed by meticulous preoperative management and expert surgical handling. These are my references. Thank you.
Thank you, sir. Thank you for showing the beautiful video also. I think in the whole conference, there are only handful of people who can do this.
Thanks for that.
Yes, sir. I think, and the courage to do this should come first rather than be courageous afterwards. So I think it's very nice to see the study. Thank you, sir.
Welcome. Any more questions? Thanks.
Next presenter is Dr. Kiran Chandran. His paper is on characterizing right angle vessel to study its role in mactal progression using multimodal imaging.
Good afternoon. Today I'll be talking on characterizing right angle vessels to study its role in mactal progression using multimodal imaging. So right angle vessels have been defined as per the Gasson-Bloody clinical staging into stage 3 mactal. Recently, a lot of interest has gone into using multimodal imaging, specifically OCTA, in characterizing the vascular changes in mactal. And Saradis and colleagues published a paper in BJO in 2021 where they studied characteristics of RAV in mactal and its relevance with mactal-associated neovascularization. So they studied RAVs as early as in stages 1 and 2 and associated disease progression associated with RAV. And even morphological changes in RAV precede neovascularization in the form of dilatation, elongation, and apparent discontinuation of the vessels and occurrence of pigment plaques. So RAV is defined clinically as per the Gasson-Bloody staging as follows. They appear as vessels with a dilated and more prominent appearance and which bends at a sharp right angle into the deeper retinal layers. So the quadrant-wise classification of RAV was done by placing an ETDRS grid into the center of the fovea and dividing it into 8 broad divisions using ETDRS subfields. So aim of our study was to determine RAV associated changes on SD, OCT and OCT angiography and to follow up cases of RAV to determine its role in disease progression as well as to study RAV associated morphological changes during the disease course. This was a single center observational study recruiting 56 eyes of 49 patients with RAV detected clinically and confirmed on multimodal imaging. So in this diagram, you can see vessels which appear as an RAV, but they are not very definitive. So using a reference standard that is whole retina slab of the OCTA, which is an amalgamation of different slabs of an OCTA, you can see an RAV which is demonstrated very well on a whole retina slab, which may be missed clinically. So using multimodal imaging is important in diagnosing the presence of RAV. So the following parameters were studied using OCT, that is outer retinal defects in the form of attenuation, where there is no obvious loss of any layers, but there is patchy loss. Then coming to loss of IDZ and EZ and loss of external limiting membrane. Then collapse of the inner into outer retina, inner and outer retinal cavitations, pigment migration, outer retinal hyperreflectivity. On OCTA, we studied the different plexuses like superficial vascular complex and deep capillary plexus are studied for the presence of telangiectasias as well as foveal avascular zone changes. In the outer retina choriocapillary layers, the presence of nodular hyperreflectivity networks as well as retinal coronal anastomosis was studied for. So 49 eyes of 56 patients, 56 eyes of 49 patients were recruited and at least 3 follow-up visits were done with a mean follow-up duration of 20 to 52 months and majority of eyes had stage 3 disease followed by stage 4 and stage 5. So as you can see in this table, majority of the OCT findings had a direct correlation to the presence of RAV. All outer retinal changes ranging from IDZ, EZ and external limiting membrane had an associated RAV to it. Followed by retinal pigment epithelial migration as well as outer retinal hyperreflectivity. So the most common associated RAV finding was with IDZ loss as well as EZ loss. Even in follow-up parameters, at each quadrant where the RAV was present, there was progressive increase in the extent of loss of IDZ, EZ and ELM as demonstrated in this table. In OCTA, RAV demonstrated telangiectasias in the DCP in all patients and telangiectasias were typically located in the temporal quadrants in OCTA and vascular invasion involving the foveal vascular zone was seen in 4 and 6 eyes in SVC and DCP respectively. The presence of nodular hyperreflectivity, network and RCA was seen in 4, 6 and 3 eyes respectively. So coming to a few examples, this diagram demonstrates the RAV associated interdigitation zone progression in mactal. On multicolor photo, you can see the presence of RAV temporally. On whole retina slab of OCTA, this RAV is appearing very prominent and corresponding deep capillary plexus shows telangiectasias which appear as slightly dilated and irregular vessels adjacent to the foveal vascular zone. At presentation, the OCT does not show much IDZ changes. This is called IDZ at risk, which appears as a serrated appearance of IDZ. And on follow-up 1 and follow-up 2, you can see the IDZ is attenuated followed by complete loss of the IDZ at the final year follow-up. This is an example which shows a detailed 10-year follow-up showing RAV-associated changes in MACTIL using fundus autofluorescence and OCT. At the initial visit, there is no changes on OCT, it appears normal. When the RAV appears, there is IDZ loss happening with subsequent increase in the EZ loss and pigmentation, which initially is non-central, which progresses to involve central fovea as well. So over here you can see a blue reflectance image showing an RAV superiotemporally, and exactly where the RAV is dipping into the deeper retinal layers, you can see the outer retina shows changes in the form of outer retinal hyperreflectivity with ellipsoid zone loss. As we progress into the disease stage over subsequent follow-ups, you can see the EZ loss is increasing and outer retinal hyperreflectivity is also increasing. And the corresponding octa slabs in subsequent follow-up visits shows increase in the nodular hyperreflectivity to form what appears as an irregular reflectivity, but almost looks like a network forming. So this example demonstrates the formation of retinochoroidal anastomosis in MACTIL. Over here, there's a choroidal neovascular membrane, subretinal neovascular membrane in multicolor photo, and SD-OCT shows the presence of outer retinal hyperreflectivity. The corresponding whole retina slab shows the presence of two right angle vessels with a anastomotic complex being formed with the underlying choriocapillaries. On outer retina choriocapillary slab, you can demonstrate the presence of a well-defined circular network. Even morphological changes in the form of vessel straightening, as you can see in whole retina slab, is demonstrated over a 4-year follow-up, with subsequent DCP showing lateral elongation of the foveal avascular zone as the disease progresses, and outer retina choriocapillary shows the formation of a well-defined vascular prominence as we progress towards the disease course. This example again demonstrates using a fundus autofluorescence that the right angle vessel, which was initially dipping inferiorly, shows a sharp deflection as a right angle towards a neovascular lesion, and corresponding OCT shows the presence of outer retinal hyperreflectivity and increase in the ellipsoid zone loss. So what was known before was that RAV was associated with disease progression and contributed to the development of neovascularization in MACTIL, but this study adds earliest changes in the outer retinal layers are directly linked to RAV, and even telangiectasis formation on octa are related to the formation of RAV. So RAV is associated with progressive increase in the loss of all outer retinal bands, and thereby suggesting that RAV can serve as an important biomarker in MACTIL right from the early stages of disease. Thank you.
Very nice study. So my question is that, do you think that those who are not having the octa, they won't be able to pick up all these things, and or in other way, is it mandatory to do octa in all such patients?
So RAV was initially diagnosed clinically, but recent multimodal imaging, especially blue reflectance imaging and multicolor photo, are also extremely sensitive in picking up an RAV, especially the green reflectance as well as the blue reflectance lab. And even FFA was initially the gold standard for diagnosing the RAV, but FFA changes get obscured once the leakage etc. happens. So octa is being employed because it's easy to do an octa and you don't miss out on subtle findings such as an RAV in following up patients.
There is no doubt about the role of octa because it's already known.
True.
So what I'm trying to say is those who are not having access to octa, so how they should, what is your recommendation?
An OCT can be done, and so for example, these biomarkers which I suggested in progressing, showing the follow-up of MACTIL, they can be followed up. And even a cursory examination, we may miss out an RAV. So you can keep a close watch on the morphological changes that develop an RAV. Even a subtle fundus autofluorescence can help actually in picking up an RAV. Yeah.
What about a simple fundus photograph with the high zoom?
Yeah, the 30-degree view definitely helps, and the recent photo I showed where they are. That is a 30-degree. Yes, sir. You can use the fundus photo with 30-degree view where you can pick up RAVs. True. Yes, sir. Sure. Thank you, sir.
Next, we have Dr. Nayana G. Her paper is on understanding strabismus and amblyopia in preterm children, its types and contributing factors.
A very good afternoon to one and all. I'll be presenting my study on understanding strabismus and amblyopia in preterm children, types and contributing factors. So, strabismus and amblyopia can be the common vision disorders that can have a significant impact on the life of preterm children. So, the previous studies has shown the prevalence of strabismus in preterm to be around 20 to 40%, while in term it was around 2 to 5%. And similarly, the prevalence of amblyopia was found to be around 10 to 15% in the preterm, while it was around 1 to 3% in the full term. So, our study was to study the types of strabismus and amblyopia in the children born preterm, now in the school going age group, and to analyze the factors contributing to the development of squint, refractive errors, and amblyopia in these children. It was a retrospective study including 152 children, now in the age group of 5 to 9 years, who were born preterm. We have included children born less than 37 weeks, now in the age group of 5 to 9 years, presented to our pediatric ophthalmology clinic, and a complete medical record was available for review. We have excluded children with any history of ocular trauma or surgery. Any congenital anomalies like cataract or glaucoma were excluded. The factors we considered included factors associated with birth history like gestational age, birth weight, and NICU stay, postnatal factors like developmental delay or associated systemic conditions, especially neurological conditions, and the ROP related factors like presence or absence of ROP, stage, and the treatment taken for that. A detailed anterior segment evaluation was done, followed by an orthoptic evaluation, vision and cycloplegic refraction, and a posterior segment evaluation was done in all those cases. And the type of strabismus, refractive errors, and amblyopia was analyzed. The association of each of those factors with the development of squint and amblyopia was assessed with chi-square test, and the mean age of development of squint was also assessed. Coming to the results, among the 152 children aged between 5 to 9 years, the male to female ratio was 1:1.2. Majority of the children came in the late preterm group between 32 to 36 weeks, and the birth weight majority came in the low birth weight group, and history of ROP was present in about 37.1% of the study population. The prevalence of strabismus was found to be 52.8%, among which intermittent exotropia was found to be the most common type, followed by accommodative esotropia. Amblyopia was present in 34.8% of the study population. Ametropic and anisometropic were found to be the commonest types. And coming to the refractive errors, astigmatism was the most common, followed by a combination of myopia and astigmatism and myopia. So, we did a chi-square test and found the association of each of the factors, and the development of strabismus was having a positive correlation with a p-value of less than 0.05 with gestational age, birth weight, the presence or absence of ROP, the associated developmental delay, and associated systemic conditions. So, amblyopia was found to be a significantly high in cases with severe ROP and also in cases which were treated with laser and intravitreal injections. There was no significant association between the severity or treatment taken for ROP and the occurrence of strabismus. And myopia was found to be significantly higher in the laser treated ROP cases. And we found esotropia to be more common in the early preterm, while intermittent exotropia was more common in the late preterms. The mean age of onset of strabismus was found to be 2.76, and for our surprise, about 38% of the cases, the onset of squint was before 1 year of age. About 28% of the cases, the parents noted squinting before 6 months of age. So, to conclude, a significant association between gestational age, birth weight, presence of ROP, and the prevalence of strabismus and amblyopia highlights the need for regular eye examination in the preterm children with these risk factors. The study's finding on the types of strabismus with esotropia more common in early preterm and intermittent exotropia in the late preterm can be used for targeted interventions. And considering the age of onset of strabismus, a regular orthoptic evaluation along with the cycloplegic refraction is recommended in these children in the preschool age group. So, what is already known? According to Vijayalakshmi et al., the existing guideline says if there is no ROP, the first examination should be done at 2 years. If the ROP, if it is not treated with laser, at 1 year the first examination and annually thereafter. If the ROP case was treated with laser, first examination at 3 months and every 3 to 4 months thereafter. So, according to this guidelines, many of the times we are getting children at 4 year or 5 years. They may be adding extra years from their this thing also. So, what we propose a new guideline. If there is any strabismus or nystagmus, the consultation should be immediate. If the child is not responding to lighter phases or if there is any features of CVI, immediate consultation should be done. And if the gestational age is less than 32 weeks, very low birth weight, history of developmental delay or ROP if not treated with laser also, the first consultation should be done at 6 months. And in cases of ROP cases treated with laser, first consultation at 3 months. So instead of telling the children for a pediatric opinion at 1 year or 2 year, it is better to educate the parents about the warning signs of amblyopia, strabismus and all beforehand, so that they can have a earlier consultation before the amblyopia or strabismus or the suppression sets in, and we can help these children. These are my references. Thank you.
Did you include all the ROPs which were examined in your, or did you have any exclusions?
Any cases which was any surgeries or any cases with any congenital anomalies were excluded, ma'am. And also those children who are not in the follow-up or who are not having the complete medical records, we have excluded, ma'am.
Because from what your record looks like, then most of them at the most received only laser.
Intravitreal also, ma'am.
But I don't think more severe ROPs were included in this, who needed surgery or who were.
Yes, ma'am. If they are presenting to, this was done in the pediatric ophthalmology clinic. So,
Yes, but, so I think you should
yes, ma'am.
mention that.
Yes, ma'am.
Those patients who are opaque, who have had lens weight, who have
Yes,
had
ma'am.
Macular are also coming to your
Yes,
clinic.
ma'am. Yes, yes, yes,
So
ma'am.
you should mention that in our exclusion.
Yes, ma'am.
You have taken you have really
Yeah.
excluded the all severe ROPs from there, right?
Yes, ma'am.
So I think that should be clearly mentioned.
Yes,
You have
ma'am.
excluded patients who could not be recorded vision because of CVI. You have excluded a whole lot of patients.
Yes, ma'am. No.
Yeah, so I think in your exclusions you should mention that. If
Yeah.
you have included only up to laser, who could be?
I have
There is
included
a
like
whole
any.
lot of selection bias in this paper.
Yes, ma'am. I have included in the exclusion criteria. I have mentioned any ocular surgeries, ma'am. So I have considered up to lasers and intravitreal. All surgeries were excluded. Thank you.
Next, we have Dr. Namita VJ. Her paper is on From In to Out, What Causes Consecutive Exotropia.
Good morning all. My presentation is on From In to Out, What Causes Consecutive Exotropia. There's no financial interest in the study. Consecutive exotropia is a manifest outward deviation developing in a formerly esotropic patient after surgical treatment for esotropia. By convention, exodeviation more than or equal to 16% diopter for distance and near is considered significant enough to intervene in case of consecutive exotropia. Based on the onset, it's divided into immediate and delayed. Immediate mainly because of a slip muscle, slip medium rectus muscle or improper suturing, and delayed cases are mainly because of stretch scar or because of late muscle slippage or because of sensory exotropia due to poor vision, amblyopia or suppression. A thorough history looking to the onset of initial squint and the primary surgery parameters along with going through the old photograms and previous discharge summary will help us in planning a proper intervention. So our aim is to evaluate the clinical features and factors responsible for the onset of consecutive exotropia in patients who underwent surgical correction for esotropia. So it's a retrospective EMR analysis for all the patients present to the pediatric ophthalmology center in a tertiary eye care center with the diagnosis of consecutive exotropia from the period 2013 to 2024. The previous surgery data is obtained from a discharge summary, serial photographs and from the EMR. All patients underwent a detailed ophthalmic evaluation including binocular vision status, cycloplegic retinoscopy, anterior segmented dilated fundus examination, and these were the parameters we assess in case of primary surgery like age at the surgery, type of initial squint, angle of deviation and the amount of medial rectus recession, and the type of surgery whether unilateral procedure or bilateral medial rectus recession was done. In consecutive exotropia, we assess the presence of amblyopia, any presence of adduction limitation, any convergence insufficiency, any presence of pattern deviation, inferior oblique overreaction, DVD, Also, we assess the position of medial rectus intraoperatively, whether there is any slip muscle or any stretch scar, or all the muscle were at the intended position. And all the patient underwent exploration of medial rectus, and most of them underwent medial rectus advancement plus or minus lateral rectus recession. And those with oblique overaction, we did an inferior oblique weakening also. And those with less than 20% diopter, we advanced only one medial rectus. Those with more than or equal to more than 20 to 25, we advance either both the medial rectus or with unilateral medial rectus advancement plus ipsilateral lateral rectus weakening. Coming to the result, most of our patients were in the age group of 10 to 20 years. The mean age was 18.10 years. Females outnumbered in our study. Coming to the primary surgery parameters, 20 out of 29 patients had primary surgery elsewhere. The mean age at initial surgery was 3.77 years. Most of them had undergone surgery for infantile esotropia. 13 out of 29 patients have preoperative angle of deviation available, of which the mean angle of deviation was 40% diopter and average MR recession was 5.41 millimeter. And majority are undergone bimedial recession than unilateral resect procedure. 41% had poor follow-up. Coming to the consecutive exotropia parameters, the duration of exotropia as obtained from the parents was ranged from, the mean was 8.77 years, and the duration between the primary surgery to the consecutive exotropia was 12.91 years. The mean angle of exotropia for distance and near was almost similar. We also assessed the non-surgical parameter and the surgical parameter, which would have led to the consecutive exotropia. In non-surgical parameter, 62 patients were amblio, 82 were suppressed. In refractory status, most of them were emmetro, followed by myope and hypermetropia. 20% had anisometropia, 17% had DVD, and patent strabismus with inferior oblique overaction was present in 31%. Coming to the surgical parameters which would have led to consecutive exotropia, we have found most of them underwent a large MR recession more than 5 with an average of 5.41, and 13.79% had convergence insufficiency, 10.34% had adduction limitation, 10.34% had slip muscle, and we found that medial rectus at intraoperatively, 3 patients had slip muscle, 1 patient had a stretch scar, and rest all had a medial rectus at intended position. All the patients had underwent exploration of medial rectus, and 51.72 patients had underwent unilateral medial rectus advancement with ipsilateral lateral rectus weakening. Coming to the binocular status, 82.75% were suppressed before surgery, of which 65.5% remained suppressed even after surgery. 6 patients attained fusion. 1 patient had a transient diplopia which almost settled by 3 months. Coming to the discussion, the incidence of consecutive exotropia after ET surgery is reported to be 4 to 27% in previous study. The main risk factors for consecutive exotropia we encountered in our study are poor follow-up. It's seen in our study the mean duration of exotropia and the duration between primary and second surgeries were more than 8 years. And once the alignment is done, most of the parents forget about the frequent follow-up, and once an outdrift comes, they will come to the clinic. We also found there was large medial rectus recession in our case series, and the previous studies done by other et al, like it was more than 6 mm of medial rectus recession as the causative factor for consecutive exotropia. However, we found that even at more than 5 mm, there is high risk of consecutive exotropia. So to limit the medial rectus recession by 5 mm, and development of amblyopia is another strong factor which was seen in the other studies also, as the amblyopic eye always has a tendency to outdrift. We also found that adduction limitation, which in turn can lead to a convergence insufficiency, instability of alignment, and can lead to a late exodrift. In case of missed oblique overaction or in pattern deviation, mainly in children with esotropia are examined in the primary position with a modified Krimsky test, and all the oblique overaction are measured in the vertical, in the up gaze or in the down gaze, and in such cases the pattern deviation are usually missed, and an oblique as such is an abductor, and overaction of obliques can lead to an outdrift. DVD, Also because amblyopia with poor binocularity can lead to DVD, and DVD is characterized in outdrift, updrift and extortion, which itself can lead to consecutive exotropia. The other factors are development of new refractive error and late scar remodeling. To conclude, poor follow-up, amblyopia and large medial rectus recession more than 5 mm is a risk factor. Inferior oblique overaction, DVD and inadequate refractive correction can also contribute for overcorrection. So all patients undergoing esotropia surgery should undergo a periodic follow-up with proper refractive correction and amblyopia treatment to prevent the development of consecutive exotropia. Limitation data collection due to a retrospective nature and a short sample size are a limitation. These are my references. Thank you.
There were 2 patients who were more than 50 years old.
Yes, ma'am.
So, what was the cause in them?
One patient presented to us at 64 years and she had history of an acute onset ET. That from the records it was available by 12 years she had undergone surgery, but she presented to us late. Ignored. She was suppressed in that time. Strabismic amblyopia was there in that time. And the same patient had a slipped medial rectus also, ma'am.
I think 5 mm is a bit drastic to say, because I think 6 and more you can say that, but 5 is looking at your data since your muscles had not slipped.
Only 3 patients have slipped muscle.
Yeah, so I can't blame that 5 mm medial rectus recession as your cause. Maybe amblyopia. How was there any correlation did you find with the visual acuity to consecutive exotropia? What was the mean visual acuity in patients who had
Visual acuity as such, I didn't check, ma'am. The amblyopia factors I checked that 62% were amblyope.
How will you say amblyop without checking the visual acuity?
Visual acuity we recorded, but into consideration.
Drifts are very common if patients have poor vision. I think
Next presenter is Dr. Neenat Jose, ocular trauma in pediatric age group, predictive accuracy, pediatric penetrating ocular trauma score.
Good afternoon, everyone. The title of my study is Ocular Trauma in Pediatric Age Group, Assessing the Predictive Accuracy of Pediatric Penetrating Ocular Trauma Score. 20 to 50% of ocular injuries presenting to hospitals occur in children. In children, delay in presentation, unclear mechanisms of injury, and poor cooperation with eye examination can make the initial assessment less accurate. Thus, a precise visual prognosis is a challenge in pediatric cases, and long-term recovery can be complicated by amblyopia. The ocular trauma score was put forward by the Ocular Trauma Classification Group in the year 2002. They also put forward a probability index. Using this probability index, the clinician could accurately prognosticate the final visual outcome with 77% accuracy. According to this prognosing system, the initial presenting visual acuity is regarded as the most important parameter that aids in the prognosis of the final visual outcome, and globe rupture, endophthalmitis, perforating injury, retinal detachment, presence or absence of RAPD are other parameters. But in children, as we know, it is often difficult to assess the initial presenting visual acuity and RAPD. Hence, in 2011, another prognostic system was developed by Ekar et al., known as the Pediatric Penetrating Ocular Trauma